High blood pressure is associated with several mechanisms how these two entities are connected. There may be a direct effect by the blood pressure, hemodynamic, but there may also be other mechanisms connecting blood pressure and atrial fibrillation. Hemodynamic changes, we have neuroendocrine factors, mainly the sympathetic nervous system and the renin-angiotensin system. We have remodeling in both the atrium and the left ventricle. We have ischemia.
And we also have other mechanisms that actually may cause high blood pressure and cause atrial fibrillation without actually linking blood pressure load and arrhythmia together. So I will touch briefly on these different issues. But first, just to show you that there is convincing evidence in epidemiology showing that blood pressure has an influence on the risk of incident atrial fibrillation. This is data from the Women's Health Study. So healthy women followed for 10 to 15 years, where you clearly see that an increase in systolic or diastolic blood pressure will increase the risk of new onset atrial fibrillation. And this gradient is obvious already from very normal blood pressures around 120 over 60 or 70 millimeters of mercury. This is then data in women in the US, but we have similar data in men. These are long-term follow-up data from Norway, from Oslo, where initially healthy middle-aged men in Oslo were followed for 35 years. And again, it's obvious that the higher your systolic or diastolic blood pressure is, the higher is the risk for incident atrial fibrillation. And again, the risk increases already within what we call normal blood pressure. These data, both in men and women, probably is a considerable underestimation of the risk of incident atrial fibrillation, because we have previously thought that atrial fibrillation has a prevalence of half or 1%. But actually, if you do more recent registry data studies, at least in Sweden, this suggests that you have a prevalence of about 3% of atrial fibrillation. And if you also include paroxysmal or silent AF, you may have an incidence, a prevalence of about 4 or 5%. So there is a gradient with blood pressure, and there is a clear risk, and it's a common disease. Also, in treated patients, there is a relation between blood pressure and new onset atrial fibrillation. These are data that we just recently published based on 45,000 patients in Swedish primary care with hypertension. And we followed them, and we could show that with a follow-up of 3.5 years, there was a higher blood pressure in those developing atrial fibrillation than in those being free of atrial fibrillation. The blood pressure difference was about 4 over 2 millimeters of mercury. And on the lower left panel, you can see that the change in blood pressure during treatment was greater in those who did not develop blood pressure. And upper right shows you that this is also true when you go to rather low blood pressure. So there is a difference between 130 and 140 millimeters of systolic blood pressure. So this, in summary, shows that if you have treated hypertension, if you reach lower blood pressure, you will have a reduced risk for atrial fibrillation, also considering concomitant factors and confounders. We have data published several years ago now from the Framingham cohort showing that LVH on the ECG is what it has the strongest odds ratio for new onset atrial fibrillation, with a 3 to 4-fold increase in the risk of new onset atrial fibrillation.
However, due to its high prevalence with hypertension in the general population, hypertension is the most significant population attributable risk for AF. And you see here an odds ratio for about 1.5 for hypertension. And definitely hypertension is very common among AF patients, and it's also very common among patients in trials on atrial fibrillation, where a majority of patients have hypertension. So there is a clear link from high blood pressure to overload to structural changes in the heart with left ventricular hypertrophy and fibrosis. I will now spend a few minutes just on mechanisms mediated by the renin-angiotensin system and by the sympathetic nervous system, which also are important and not necessarily go through an increased afterload and blood pressure. These are some data we published a few years ago showing that myocardial fibrosis, if measured by circulating biomarkers, in this case P1CP, which is a marker of collagen 1, there is a relation between fibrosis measured by P1C1 and left ventricular mass index and blood pressure, but there is also a relation to diastolic dysfunction measured here by EVART and also by filling pressures. So it seems like diastolic dysfunction and increased filling pressures are related to an increased myocardial fibrosis. And indeed, if we compare matched groups with normotensin, with hypertension without LV hypertrophy, and with hypertensive patients with LV hypertrophy, you can appreciate here that collagen content measured at P1CP is increased already when you have hypertension without hypertrophy. And that seems to go hand in hand with a reduced diastolic performance with diastolic dysfunction, suggesting that myocardial fibrosis precedes myocardial hypertrophy. Of course, we cannot say from these studies whether this is in the atrium or in the ventricle, but a good guess would be that it's present in both the left atrium and ventricle. And as you all know, there is a clear relation between left ventricular hypertrophy and arrhythmias, both for supraventricular and ventricular arrhythmias, and this is, of course, also true for atrial fibrillation. Angiotensin II is a key player because angiotensin II has a lot of effects and also clear arrhythmogenic effects. Obviously, angiotensin II will increase wall stress and stretch in the atrium. It will facilitate noradrenaline release through a prejunctional effect, and that is also present in the heart. It will also inhibit central vagal activity, which is proarrhythmic. As I mentioned, angiotensin II promotes myocardial fibrosis, and it will decrease conduction velocity and will disorganize cell-to-cell coupling with an increased dispersion and with a change in action potential. There is also a stimulation of myocyte growth, and then we have the proatherosclerotic effects with vascular changes in the myocardial vasculature with promotion of ischemia. So there are arrhythmogenic effects on angiotensin II directly on the myocardial cells. It is also important to remember that aldosterone is an important player because aldosterone may be very strongly related to fibrosis, not to myocyte growth, but rather to fibroblast growth and myocardial fibrosis. And here you can appreciate that aldosterone excess will stimulate inflammation and will also stimulate extracellular matrix with fibrosis, and that will again promote atrial fibrillation. And actually, if you compare patients with primary aldosteronism or essential hypertension, and this is rather large material with 124 patients with primary aldo and some 450 patients with hypertension. These two groups were matched with age, sex, blood pressure. Obviously, serum potassium is lower in primary aldosterone patients, but the rate of stroke, of myocardial infarction, of atrial fibrillation, and LVH is considerably higher in patients with primary aldosteronism. So, excess aldosterone is clearly linked to an increased risk of atrial fibrillation, independent of the effect of blood pressure. If I leave the renin-angiotensin system and just change over with a few slides on sympathetic nervous system, this is just to remind you that hypertension is associated with an increased sympathetic nerve activity, shown on your left. And the sympathetic nerve activity is accomplished by an increase in noradrenaline release and a decrease in neuronal reuptake of noradrenaline. So there is an increase of noradrenaline in the synaptic cleft. If we go to another condition which I think is relevant here, that is obstructive sleep apnea, that is also characterized by an increase in sympathetic nerve activity, shown on your bottom right, here in comparison to non-sleep apnea patients, and these were actually heart failure patients. So obstructive sleep apnea is a model of an increase in sympathetic activity, which you will see is relevant for atrial fibrillation. It's very clear from several studies that sleep apnea patients have an increase in sympathetic nerve activity, and that is clearly linked to the hypoxia and the suffocation or almost suffocation during apnea, and that can be normalized by CPAP treatment in patients with hypertension. The link between obstructive sleep apnea and atrial fibrillation is also obvious. On the top left panel, you can see that the prevalence of atrial fibrillation and sleep apnea is very high, and it's more common with sleep apnea in AF patients than in general cardiology patients. Almost half of the patients with AF have obstructive sleep apnea. And the risk for having atrial fibrillation if you have sleep apnea is very strong, as is shown on your right-hand panel. What happens then? If you have sleep apnea, basically you have your airways obstructed, and as shown on the top panel here, you see that there is an occlusion of the upper airway, and there is a lower intrathoracic pressure, and there is an expansion of the ventricle and the atria. And this pressure is very large. It can be minus 40 or minus 50 millimeters of mercury. So there is a strong mechanic component. In the acute phase, as shown on the bottom left, in the acute obstruction, you have these pressure changes, you have hypoxia, and you have influence on the sympathovagal imbalance. And that will trigger extrasystoles, and that will also cause a shortening of the refractoriness of the atrium. In the chronic condition shown on your bottom right, you will see that there is this chronic sympathetic activation, you have a dilatation of the atrium, you have activation of oxidative stress and inflammation, and obviously you have comorbidities with hypertension and obesity, and that will cause then hypertrophy and fibrosis of the atrium, re-entry, and atrial fibrillation. So there are different mechanisms in the acute and the chronic state. So there are many mechanisms by which obstructive sleep apnea can cause atrial fibrillation. They are mediated very much by sympathetic nerve activity, and in a way this is similar to the pathways by which hypertension also can induce atrial fibrillation. What is interesting in this content is that CPAP can actually reduce arrhythmias and prevent new onset atrial fibrillation. This is a Japanese study with almost 1,500 patients that were referred for evaluation of suspect obstructive sleep apnea. And finally, patients with moderate or severe sleep apnea were randomized, were treated with CPAP. And on the bottom right, you can see that after CPAP, the reduction in both atrial and ventricular arrhythmias are significant. And it seems like treating obstructive sleep apnea with CPAP is a very powerful way of treating arrhythmias, which I think is something which is not fully recognized. So in summary, there is a strong association between blood pressure and incident and prevalent atrial fibrillation already within the normotensive range of blood pressures. Hypertension is the most significant population attributable risk for atrial fibrillation, and there are several mechanisms that contribute to the development of atrial fibrillation in hypertension, such as hemodynamic changes, but also neuroendocrine factors, myocardial fibrosis, left ventricular hypertrophy, and direct electrophysiological changes, and of course ischemia. Antihypertensive therapy reduces the risk for new onset and recurrent atrial fibrillation, and I think this is very much under-recognized. Obstructive sleep apnea is a common condition in hypertension and in atrial fibrillation, and treatment of sleep apnea will reduce the arrhythmic burden. And finally, proper blood pressure control is important to prevent atrial fibrillation and to reduce the arrhythmic burden in hypertension. Thank you.